हेलो। 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 हेलो 1 2 3। हेलो। 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 हेलो 1 2 3। हेलो हेलो। मेरे ख्याल से ठीक है, हाँ। उसमें ऑन करो जरा। लैपटॉप पे ऑन करो। लैपटॉप पे ऑन करो। कपिल सर कंप्लीट। अच्छा बस ठीक है। तो उनके लिए कौन सा वो तो कॉर्डलेस वहां से करेंगे। हाँ। तो वो हाथ से लेके कर देंगे। ठीक है, हाँ, हैंड वाले से आप कर दीजिए। हेलो। क्लियर आ रही। ठीक है, बस यहाँ पे लगाना है, इस वाले पे। ठीक है, मैं ही लगा। नहीं सर, खरी चीज तो करेंगे नहीं ना। इनका तो जाएगा इसके लैपटॉप से। और हम उसको जूम कर देंगे 4 लोग। हाँ मतलब आप चाहते हैं ये लोग नहीं आएंगे, नहीं आए ना। तो जहां तक बैठेंगे वहीं से बस कैमरा जूम करें। हेलो। 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 हेलो 1 2 3। हेलो। हेलो। हेलो।
हेलो। हाँ, पहुंच गए आप? हाँ, 3500 में करा देंगे आपका। ठीक है, 3500 में करा देंगे, आप पहुंचिए। तो भैया आपसे कह तो रहे थे। हाँ, क्योंकि देखिए दवाइयों का खर्चा भी आएगा। हाँ देखो, वो एक बड़ा अस्पताल है। यहाँ आपकी दवाइयाँ भी सस्ती पड़ेंगी और वो भी कम रहेगा। आप यहीं आप यहीं रुकिए, वहां मत जाइए आप। ठीक है।
Could you start? Yeah. Good morning to all. It's a proud privilege to have Professor Somnath with us, and it's a the topic which is going to deliver the oration is management of asthma and exzema in children. It's a very important topic, and asthma, as you all know, is increasing in our country. Maybe many reasons, but air pollution is one of them. So, what we do is we start the function by welcoming our dignitaries. May I request, please welcome Dr. Somnath ji. You can come from inside. Hello, dear. Come from inside. And Vinita ji, you may please welcome Professor Talwar. Madhuri ji, please welcome Dr. Y.K. Gupta. And Sheetal, please welcome Dr. Behra. The scientific session would be chaired by Professor Digambar Behra, and I request Dr. Behra to take the proceedings further. Thank you. Over to you, sir.
Thank you, Professor Kapil. A very good morning to all of you. Professor Somnath, would see Professor Talwar, our former president. Then obviously he has many more things, sir. So I'm not going to. He was the former director of PGI Chandigarh and the MCI Medical Council of India chief, and many to his credit. He's a Padma Bhushan awardee also. You all know. Then our council members, I could see Professor Gupta, Madam Anita, Professor Piyush Gupta, and then the state coordinators are here, and the other members. We have got guests. I think it is great that they have come from all the way from Chandigarh. The Ms. Matthew and Dr. Pankaj, they have joined here physically. So welcome, both of you. And I think from AMC we have got our guests. They have joined here. From ICMR, good to see Dr. Manjula. Then all other friends who have joined online through the Zoom link. I could see Professor Rajendra Prasad, our council member. I could see the Professor Chudamani, our former president, and many more. It is not possible to name everybody in person. So welcome to this important session, academic session. As you know, Professor Somnath, we are really grateful to you for you have kindly agreed to deliver this lecture for our benefit, our fellows, our members, not only who are present here, but it is being beamed throughout the country. We'll be knowing more than I think 1,000 fellows and more than thousands of members of the society. So that is being beamed. Just to tell a brief about the National Academy, I am sure you know a bit about the academy. It is the highest academy body of medical and the medical scientists. Unlike the professional societies, like any, say, for example, I am a chest physician, so we are only professional societies. But this academy is a conglomeration of all the specialties in medicine and biomedical sciences. And it has a very great, glorious past. And it is an autonomous organization under the Ministry of Health and Family Welfare. And we have got many, its main mandate is to give advice and continue activities on the field of medical education, biomedical research, and healthcare delivery system in the country. And that is what we are doing over the years. And many, the who's who of medical science in this country are part of this academy. So, in fact, you will be glad to know that over 60 Padma awardees, different Padma awardees, are the part of this academy. And then I just told you about Professor Talwar. He's a Padma Bhushan. He had headed this one, and then many more people. You must have heard the name of Dr. B.C. Roy. He was from Calcutta. Yeah. So he was also its president at one time. And then we have got over 1,000 fellows. One of the important activities of the academy is to award fellowships, memberships, associate fellowships. We have got also the international members who are international scientists who are also our fellows. We have got members, we have got about thousands of members. And then we have got our regular activities we carry on, like, the for the postgraduate medical lectures, we have got regularly, we hold that. And it is managed by a council. So we will give you a brief because it will take little time if I go on telling everything, but we will be giving you a brief a booklet to you so that you can go through it.
Thank you.
So now, ladies and gentlemen, this type of lecture, we invite the eminent personalities in the field of medicine and biomedical science. So this time, Professor Somnath, he had kindly agreed, as I told you, to deliver a lecture for all of us. So he had graduated in medicine from the Medical College, Kolkata. He was subsequently admitted as fellow of the Royal College of Pediatrics and Child Health in the United Kingdom. His research in the cystic fibrosis led to the Doctor of Medicine from the University of Bristol, and his research in lung physiology, he was awarded the PhD degree from the University of Dundee. Professor Mukhopadhyay worked as a clinical senior lecturer and a reader in Dundee from 1997 to 2007. Sir, welcome, sir. Professor Srivastava is here. He is our former Director General of Health Services, Government of India. Welcome, sir. He also has been the joint head of the Department of Medicine for the last 3 years. His research, his work on the role of skin barrier function and other gene variation in allergy-related diseases has led to a change in the management of pediatric asthma and exzema. This has become life-changing for the most severely affected patients. Research evidence was used to establish a new person-centered clinical approach, and that is care for the children under 6 months of age. So researchers at BSMS, in partnership with the Royal Alexandra Children's Hospital, are currently exploring the importance of public engagement with research This work seeks to understand the unique interplay of genetic and environmental factors affecting individual children suffering from allergy, asthma, and exzema. So his research seeks to bring benefit to young patients through the development and testing of stratified medicine-led interventions that improves the outcomes for children with asthma and allergy. So eventually that leads to adoption of new ways of treating these conditions. You know, the asthma and allergy is a very important problem in case of children. If I talk about our country, you know, the IJAC study that shows in different parts of India, the prevalence varies between 3 to 18% of children in this country. They suffer from different types of allergy, and although the recent reports show that there is some decline, but by and large, I think as physicians, pediatricians, more often they can tell you the I think the general belief is that they are increasing. So, sir, your talk today will be giving us a new insight, and specifically the personalized therapy about the role of beta receptors and how we can tailor the therapy to particular patients. That will be quite useful, and I am sure all of us will be benefited. So now I'll request Professor Talwar and Professor Gupta to co-chair this session, and they can moderate this. So maybe, sir, if you can tell some few words, something, can also tell.
Thank you so much, Professor Bera. Thank you so much, Dr. Somnath, for agreeing to visit Academy and also deliberate on your the work that you have been doing. And I had the opportunity to hear him last year, Dr. Bera, in Rishikesh. And I think the future of allopathic, if you think we are now moving towards personalized medicine. The time has come now for each disease, each individual. And I think that was when I heard his lecture. So I thought this one topic we have been talking about, but there is something that in particular kind of ailment, how you can sort of using this particular strength. So I think proteomics, genetics is becoming very important to identify not only that the right drug for the right person, because everyone this in a each same thing may not fit everyone. And so how this knowledge is expanding, and I think it was very impressive to hear him on that, and that's why I talked to Vera that that's one area. I think then I'm happy that PGI Dr. Matthew is here, then his colleague Penda and Dr. Jat from AIMS. I think he's visiting AIMS after this. He's also there. Thank you so much, Doctor, and we all look forward to your very interesting work. Bakpal, please.
You can tell something, sir, Professor.
Thank you very much, sir. And I'm really indebted to Professor Talwar and Dr. Bera for giving me this opportunity to moderate or co-chair this session. The bronchial asthma has been an important disease right from when we were doing our undergraduate days till now. The situation has changed, it seems. The simple method of treatment by long-acting beta-adenoreceptor agonist, which is everybody uses that. And it is not surprising that not all children get benefit out of it. And there are some people may get exacerbation or may not respond at all. And the answer lies here that there is a genetic polymorphism with the beta-2 adenoreceptors. And that could be reason why some method need to be developed if economically viable, if feasible, at the places where the treatment is to be done. Can we filter those patients who will respond better to LABA or those who require alternate strategy? And if that can happen, perhaps this will be a wonderful thing which will revolutionize the treatment of particularly the bronchial asthma and also eczema in children particularly. The issues, I think I have just gone through quickly gone through the PPT which he is going to make it. The issues is that now all AIIMS gradually are developing genomic facilities. Even Jammu has developed genomic facilities. We inaugurated it. The issue is this genomic facility economically viable for the public to be given to routine, or this need to be subsidized, or this needs to be made affordable by supplementing R&D by Department of Biotechnology and ICMR, things like that. And so that this, which we have been talking for last maybe 15 years, ICMR, there are task force of genomics and things like that. But today, I think with this lecture, it seems that apart from cancer, epilepsy, and the bronchial asthma also seems to be a very versatile area where the genomic analysis would be very useful. So I am extremely excited with particularly this being related to pharmacology. So I am really excited. And I thank you very much again, Dr. Bera and Dr. Talwar, for giving me this opportunity. I wish that you deliver this talk to a larger audience, particularly in a pharmacology conference or things like that. But they will extremely benefited from this.
Very pleased. Shall I start?
Yes, sir.
Can you all hear me okay? Good. Sure. Thank you very much. Thank you very much, everyone, for your very kind invitation. I came here, as I was saying to Professor Talwar, I came here on holiday, like I always do. And then I just thought this is a wonderful opportunity to start talking to everyone about our one size, but I quite like using the phrase one size fits one, because at the bottom of everything, at the end of the road, is the importance of communicating with patients. So talking of precision medicine and so on is a very kind of medical concept. One size fits one is a way, I hope, to get across to the patient on the street and to say, look, this is the shift that we want to make, from one size fits all to one size fits one. And we have recently started an Instagram and Twitter account. Please follow us. I hope you might be able to keep in touch with us in terms of our research. Let me move on to what I actually mean by precision medicine, or indeed one size fits one. Well, this slide does say current. It's not actually strictly current, and I will go into this at the next slide. But if you look at the asthma management of children in particular, I'm a pediatrician, so I'm going to focus on children. It's very important to understand, of course, that this is not just about children, it's about everyone. And also, it's not just about asthma, it's about cardiovascular disease and so on. And so the reach of precision medicine is right across medicine. I expect there will be a paradigm shift in the way we treat patients over the next 20, 30, 40 years. It's already beginning to happen, but it's a very, very major paradigm shift that's likely to happen. If you look at asthma management in children, as I was saying, you will find that it is very much a one-size-fits-all approach. So you've got a stepwise increase, you've got the regular preventer, you've got an add-on therapy, additional controller therapies, and historically there has been little opportunity for variation, but personalized medicine is beginning to happen. And if you look at the latest asthma guidelines, either from GINA, and GINA is our kind of leading body right across the world, the global initiative for asthma, and our British Thoracic Society in the United Kingdom. And the small print on the top will tell you that there's a little box saying personalized asthma management. So the whole idea of personalized asthma management is creeping into the broader system of managing asthma right across the world. This slide still has ERS on it because my clinical senior lecturer, thank you, Tom Ruffles, was invited to the European Respiratory Society webinar just a couple of months ago, and he had prepared the slides and I have basically got them off him. But you can see how personalized management is becoming important, and they are really keen to hear. But it's a small box now. It's a small box still. And there is a much larger story to tell. We all know this. And indeed, this is probably one of the first major publications that woke us up to what might be going on. We all know, as respiratory physicians, and there are a lot of respiratory physicians around me at this moment, we all know that when we prescribe medicines to people with asthma, be it children, be it adults, most people improve, some people do not. Some people do not. We often say, you haven't got the right technique, you're not taking the medicine properly. And of course, these are genuine causes. But beyond that, a lot of the population seem to have what we say is difficult asthma. They keep coming back to hospital, they suffer. Some of them developed chronic lung changes and so on. So this study, which as you can see was published in the New England Journal of Medicine 15 years ago, was an eye-opener. It was not meant to fulfill this particular purpose. It wasn't meant initially to answer this question. The main question was, when you are stepping up therapy, which means that you've got children who have got, I think this is a children's asthma study. So it was pediatric asthma we were talking about. You've got children on inhaled steroids who are not being well controlled. You step up treatment, and the trial group, Lemansky, the leader was Lynn Taussig, whose name is well known right across the world. Professor Taussig was one of the leaders in the field in the second half of the 20th century. The idea was to compare three different forms of therapy. Therapy with LABA, so that will be LABA meaning long-acting beta-2 agonist, plus the inhaled corticosteroid that the patient is on. The second method that was being trialed here is stepping up inhaled corticosteroids, say from 400 micrograms a day to 800. And the third is the use of leukotriene receptor antagonists, so LTRAs. So these are the three different modes. And it showed, definitive trial, it showed LABA is the best. LABA is the best. And that's how the use of long-acting beta-2 agonists became embedded into our practice. But look at this figure. Look at this figure, and you can see that if you compare LABA with stepping up inhaled corticosteroids, look at the top bar chart. This is really important. To me, this is the birth of personalized medicine in children's asthma. You look at the comparison of LABA with inhaled corticosteroids, you find LABA is better in most patients. But is LABA better in all patients? No. Stepping up with inhaled corticosteroids is better in some patients. You look at LABA versus leukotriene receptor antagonists, LTRAs. The same story. There is a substantial minority where LTRA is better. What's going on? Are we here to treat the majority? Are we here to treat everyone? Now, this is where personalized medicine, I think, is important. And we don't really knew at that point, perhaps, what was the main mechanism underlying this, but clearly genetics is crying out as the answer. And of course, these papers kind of coincided with the embedding of the Human Genome Project. And of course, every politician in the world seizes opportunities where they can see them. And the Human Genome Project was clearly the thing of the future. So we all know and believe that the Human Genome Project will give us these answers, which will take medicine into the 21st century. And in some diseases like lung cancer, it's pretty obvious what needs to be done. In some diseases like breast cancer, where patients have BRCA1 or BRCA2, there is hardly any other option. People will go for the appropriate therapy. People who have got the money are going for mastectomies and so on, because they do not want to face the risk of early life breast cancer. The situation is different in chronic diseases. So you've got chronic asthma, for example, as a model here. It's not black and white like that, yet it means that there is a lot of suffering for a lot of people. And if genetics is playing a role, then how do we bring that into our treatment pattern? And as Professor Gupta just mentioned, it's not easy. This has not been done. We are all doctors. We haven't been sitting in the clinics taking saliva samples for genotyping from our patients. It's a whole new paradigm shift. Is it going to happen? If it is going to happen, how are we going to make it happen? It is a bit like, and this is a still from a 1959 Bengali film, which any Bengalis here will probably be familiar with. It's about these pilgrims who are trying to get to Mataji Hinglaj's temple, and they know where they are going to, but the route is arduous. The route is unknown. And I sometimes feel that with the introduction of personalized medicine, we don't have a roadmap. It's not like you've done a simple randomized control trial, X versus Y. Y is better, use that medicine. No. Here you're talking of a whole new culture change in the way we treat chronic diseases. Children's asthma is just but an example. And the same holds true, I am sure, for coronary heart disease and so on. So I thought this picture nicely summarizes where we stand at the moment. And we were advised by the Royal College of Physicians. They produced a very timely working report, which led us to come up with this kind of a roadmap, if you want to call it, a roadmap in that we felt that the first step, of course, is to be able to explore, is it beneficial? You have to show through straightforward randomized control trials, is it beneficial? Is it feasible? Can it be done in a clinic setting? Do people want this? I think is very, very important. In a world where increasingly patients have the final word, do people want this is very, very, very important. And of course, as Professor Gupta just pointed out, value for money. Is it going to be cost effective? Is it going to be, and he mentioned the options very nicely, is it going to need some funding from the government? Can it work? Can it just be rolled out? And these questions are just as relevant for England as they are relevant for India. So here we go. Let's go back to that slide from the Lemanski et al. Paper, where we looked at LABA versus inhaled steroids. We have to focus on one particular area. These small steps, a journey. What was that statement attributed to Gandhi? Every single journey begins with a single step. It's a bit like that here. You have to start off with one. And we thought this is a very useful, very important step that we can start off. Because we know from laboratory research that at position 16 of the beta-2 adrenoceptor, which is, of course, the critical player, beta-2 receptors bind with beta-2 agonists such as salbutamol and salmeterol play a very important role in asthma control. I don't need to tell you anything. You're all very highly qualified medical people. So At position 16 of the beta-2 receptor, you have genetic variation, common genetic variation. It can be either arginine or glycine. So you can have arg-arg, you can have arg-gly, or you can have gly-gly. And work by Stephen Liggett, and this goes back to 2000. So this work was done in the 1990s. Work by Stephen Liggett at the University of Yale, United States, showed that if you have arg status, this is purely laboratory work. This is on Chinese hamster ovary cells. If you have arg status, you respond less well to beta-2 receptor agonists. So if you fire these cells with beta-2 agonists, then the gly Chinese hamster ovary cells will respond best. The arg cells will respond worst. The arg-gly will sit somewhere in between. This is purely laboratory work and not even in humans. And we decided to take this forward. And this one slide summarizes about 10 years of work, not just by us. We worked on the Breathe cohort and the Pages cohort. As you can see, there are two of those. They're mainly in Scotland, some work in England, but Gala-2 is from the United States, and Pacman is from the Netherlands, and PAS is from Liverpool. So right across Europe and the United States, work was done for about 7 or 8 years. Our first paper was published in 2006, the follow-up paper in 2009, and all these papers came out around the same time. And what it showed, essentially, was that asthma attacks, which are one of the most expensive, certainly in the United Kingdom, I don't know the exact figures in India, it's a very important expense for the health service. It's a very important expense in terms of social costs for families. If you have the arg genetic status, which is present in 16% of the population, you have a greater risk of exacerbations when LABA is used in patients with asthma, in children with asthma. So GG, gly is present in 37%, arg-gly in 47%, and arg-arg in 16%. If compared to GG, you have AG, then you have a 1.52 increase in odds. So there's a 52% increased risk of exacerbation. It is per genetic step. So if you go up to arg-arg, then it's 52%, and then another 52%, it goes up. The chances of having asthma attacks. So here, there was a clear message that a commonly used controller medicine for asthma was leading to a greater risk of asthma attacks in association with the use of a particular common medicine. And the mechanism, again, really goes back to fundamental work by Stephen Liggett in Yale and further work by Brian Lipworth, my colleague at the University of Dundee. He's a clinical pharmacologist. You'll be pleased to hear, Dr. Gupta. So he's a clinical pharmacologist that give birth to ideas that eventually create paradigm shifts within medicine. And he showed how agonist-induced downregulation leads to uncoupling of the beta-2 receptor, impairing the efficacy of the beta-2 receptor response. I'm not going to go into the finer details of this because it will take me a very, very long time. So this is not the first trial we did. The first trial that we did, and I haven't got a slide for it, was actually based in Scotland, where we did a very artificial study. We picked up, because we had quite a large genotyped database of children with asthma, we picked up the ones who had arg-arg status, who were uncontrolled on inhaled steroids. We picked them up. And we had about 60 of them there. We randomized them to long-acting beta-2 agonist or montelukast, LTRAs. We randomized them. Now, if you look at the conventional learning, then the majority will respond better to LABA compared to LTRA. That is what the New England Journal of Medicine paper says. But if our hypothesis is correct, that children with Raj will respond better to Montelukast than to LABA, than to long-acting P2 agonists, then the results should go the other way around. Is that clear to everyone? This is a critical point in our hypothesis that we tested in patients. Artificial situation, we genotype those patients, we pick up the ones artificially that are judged, and we are testing the kind of somewhat outrageous hypothesis that these patients will respond to LTRA. We published these results in Clinical Science in 2013, and right across the board, the R-Judge patients did a lot better on LTRA than on LABA. LTRA has its own problems, we know that. So it's not like Montelukast is the perfect medicine, but purely in this group, it is working better. And there are lots of options nowadays in terms of muscarinic receptor agonists and so on. So the field is rapidly changing. This led us to the PACT trial, which was funded by Action Medical Research, a children's charity in the UK, and also by the NIHR, which is the research wing of the NHS. And here we went right across the United Kingdom. We randomized children between 12 and 18 to genotype-based therapy or standard NHS therapy. Standard NHS therapy, the doctor will treat as they feel is appropriate. And usually the doctor will find it more appropriate to treat with LABA because that's what the protocol says. Genotype-based therapy will say, and in our trial we said, which rightly or wrongly, we said Rj and Rj-GLI as well, because we found a 1.52 stepwise increase even with the heterozygous state. We said, okay, they are going to be treated with LTRA, and the GLI ones will be treated with LABA. So does prescribing of second-line asthma controller medication according to ARD16 result in an improvement in quality? And the primary outcome we went for was asthma-related quality of life. Because that is what matters to children. Your lung function test doesn't matter. Your, what change there is in airway resistance doesn't really matter to the child. What matters to the teenager is the improvement. Can I play football? Can I climb steps? Can I have a normal life? And that is Tom behind me there. Tom has been working with me for, I think, about 10 years now. He started off as a specialist registrar. He's now a consultant, and he has done sterling work on this and many other studies. And so this is the design of the study. As I was explaining, you screen, and at enrollment, you randomize one to one, this side, one to the other side, personalized care, controller prescribing as per genotype, standard care, as per BTS guidelines, as per NHS policy. And you have a run-in period for everyone, and then you have the treatment follow-up period, which is for a full year to look at quality improvement. Now, I really must pause here and say, please do not think this is the only way you will practice personalized medicine, particularly the younger ones in the audience. We'll be dead and gone. The younger ones who will be working here in the field of medicine for the next 30, 40 years, this is not the way it's going to happen. You will do it with a lot of other medicines. You will do it with inhaled steroids, and there's clear indication that can easily happen. We are waiting for somebody to take up the gauntlet and to pursue those studies. It will happen. It will happen with salbutamol as well. We've got some early data, which we are keen to publish soon. Indeed, we are presenting this at the European Respiratory Society meeting in Amsterdam next month. So so this is how it was designed. And what we found was that if you look at pediatric asthma quality of life, you find that there was a significant improvement in quality of life, in children's asthma-related quality of life, for both the ARJARJ and the ARJGLI groups. It wasn't massive, it was small, but if you concentrated on the ones who are AA, you got a much bigger mean difference, and that was actually greater than what is called the minimal effective, I can't remember the phrase. So it was above what would be significant to the patient in clinical terms. So if you are ARJARJ, then it matters, is the important word here. Okay, so while we were working on this study, the Dutch were at it too. And the Dutch, instead of our plan, which was using the LTRA, in Europe, the use of the doubling of inhaled steroids is more popular. So they went for double dose inhaled steroids, and they tried to run this study between the Netherlands, Switzerland, and Italy. But unfortunately, they couldn't recruit the number of patients. We did it within the United Kingdom. They couldn't. And then when we published our paper, they came to us and they said, we've got all this data in about 100 patients. We aimed for 200, we didn't get that. Can we have your data, please? So we can combine the two together. The intervention will be different, a little bit different, in that you have gone for LTRA, we have gone for inhales, but the underlying pharmacological principle is the same. So can we do that? And we said, yes, that's a great idea. Go ahead and do it. So this is Elise Slob, who was the slightly disappointed research fellow, not having been able to recruit all our patients, but she's very energetic, very, very enthusiastic, and her supervisor, Anke Hilse Maitland van der Zee, who was then professor of precision medicine and lung disease at the University of Amsterdam. She's now moved to some other place as the head of Department of Genetics. So this paper has just been published, and essentially Elise combined the two data sets and explored asthma exacerbations, because that was the main outcome that came out in our meta-analysis. And this is what she found. She found that if you combine the two cohorts together, then there is a significant decrease in exacerbations with genotype-driven therapy compared to standard therapy, as was practiced in both the Netherlands and the United Kingdom. So do people want this? I think this is very, very important. And indeed, the initial study, how long more do I have, Professor Behar? Please continue. He has given me a open check here, blank check here. Do people want this? I think is very, very important. Because, of course, if the people don't want this, what are we fighting for? Would they be happy for genotyping to be done? I mean, I would have perhaps said 5 years ago, people in the West are very cautious about giving their genetic. I don't say these things anymore, because I think people in India are just the same. They are becoming more and more and more conscious of their rights. And yes, they react exactly the same way. So is it acceptable to use genetic information to guide asthma treatment? And this study was not done by us. This was done by a guy called Daniel Hawkett, who is based in Liverpool. And he did a very nice, not with reference to a particular trial, but he interviewed families, he talked to people, and the overwhelming message that came out in Dr. Hawkett's study was that people say, get on with it. If it's going to improve my child's life, go ahead, please. I'm happy for genetic information to be shared. to be shared amongst healthcare professionals, there's only one thing they said, which is probably important to say to everyone here. We don't want industry to lay hands on my child's genetic data. This is one message that came out right across the United Kingdom. We trust universities 100%, but we don't want industry to lay. We don't want insurance agencies to lay hand on our data. So that was the concern. And it's something to keep at the back of our mind, well, not at the front of our minds when we carry out similar studies. So yes, this was the message that Hockart study showed. When we then thought, we had incredible support from our local NHS. They were really excited at this. That, Brighton was kind of at the forefront of something that could lead to internationally significant discovery. So they funded a clinic in our beautiful children's hospital. And Tom did a lot of good work there. He managed to get together research nurses. We've got some very good junior doctors as well who have joined up with us. And he did an initial study, which the results of which are being presented, as far as I can remember, are being presented at the Amsterdam ERS, but he's also in the process of writing up the manuscript. And it assesses the feasibility and acceptability of a beta-2 adrenoceptor genotype-guided personalized medicine clinic. So roll it down to the clinic level, no randomization, nothing. Children 4 to 15 years with asthma, poorly controlled on regular inhaled steroids. You do the clinical review, you administer quality questionnaires, you take the saliva sample, do the genotyping, follow up after 3 months, and see where you get to. And we did this for about 30 odd patients. And it was very interesting to find that even with this relatively small sample, of course, these patients had asthma that led to symptoms on everyday life, had a variable impact on the medication use. The medication burden was prominent, and everybody felt there was room for improvement. People remarked on the ease of the saliva test and the improved symptom. This is not a randomized controlled trial, but clearly the message was coming out. People were happy with this kind of treatment in this clinic setting, decreased reliever use, and the desire for others to benefit. So if you look at some of the comments that came from the children and from the parents, it was quite telling. It was teaching us where this was going. So this from a mom, one size definitely does not fit all. I think everyone needs this. I really do. And this 15-year-old girl says, we are not all the same. So it seems crazy that everyone should get the same medication. These are children who have really suffered from asthma. And then dad saying he was much better at remembering to take his medication, which brings forth the whole new story of adherence. And we say, you're not taking your medicine, that's why you're not improving. Well, could it be, I'm not taking the medicine because the medicine isn't working? Why the hell will I take the medicine? So, there are many different aspects to this, and we doctors have to wake up and recognize this. And there's this lovely comment from Jack as well. So do people want it? Which is what has led us to go for an active public engagement. I think public engagement is so important. And please do scan in, or please do join Onesizefits1 on Instagram to keep in touch with Olivia Cottington, whom some of you have already met. She was with me in Rishikesh, and she is the driver behind this program. So she is she's an administrator, but she's got strong media skills, and she is kind of driving the work behind this program. And I think in any kind of mass rollout, we need to have public exhibition events where we take these ideas into the community, get their feedback, and as I think Olivia quite likes saying, building digital community spaces to share health and knowledge. I like that. So let us take ourselves along that route here the road to implementation. Do people want this? I think we are getting a strong message that people do want this. Is it beneficial? I think randomized control data is strongly pointing towards it. Is this feasible? Well, it is feasible because we are doing it in the clinic setting. Of course, it would need modifications. Value for money is very, very important. It's as important in India as it is in the NHS in England, because England has got massive funding issues in terms of delivering healthcare. We all know that. So what we did at this stage, this is in the last year or so. I haven't presented this data in Rishikesh. This has happened over the last year, and I think this made it worthwhile coming and talking here. We collaborated actively with the University of Manchester, who has got probably the strongest Department of Health economics anywhere in the United Kingdom, and possibly, I would argue, across the European Union. And this was driven by a body that the NHS has created over the last 2 or 3 years. And it's called the NHS Network of Excellence for Pharmacogenomics. The whole idea is that they've been funded to pick up these developing interesting areas within the whole gamut of medicine. So statins is a very important area because, of course, statins is a much more commonly used medicine, I suppose. I don't know if it's much more common. Probably is. And it's got major cost implications. And so statins and clopidogrel is a very big area which I know absolutely nothing about, of course, being an asthma doctor. But they were very strongly attracted to our work. And this is a, you could say this is a hypothetical analysis. This is an analysis that they did on the basis of our existing data and the Dutch data. And it's really interesting the way they did it. The objective was to evaluate whether genotype-guided treatment for asthma is clinically effective and is good value for money when compared to the usual approach. They looked at a group of children between 6 to 11 years where persistent asthma uncontrolled with persistent uncontrolled asthma at step 2, which is inhaled steroids monotherapy, where they required the add-on therapy. The intervention we decided to go for ARJARJ subgroup being prescribed the Montelukast, ARJ16 and GLY being prescribed salmeterol, because clearly the strongest signal was coming for ARJARJ, which is still about 15% of the population. Comparator was usual care. Outcomes was NHS costs. And it was follow-up for about 6 years or so, from the start of age 6 to the end of 11 years of age. So the analytical model was this: a patient ages 6 years of age come in, and as I explained, the ARJARJ, they could follow all these different. So it's interesting how they do this. And it was a learning experience for me. I still not learned anything, but you can have symptom-free and then symptomatic, mild exacerbation, severe exacerbation. All these possibilities, including death, is a possibility here.
We don't hear anything. Something has gone wrong. This is probably at the NAM's office level because I think otherwise all of us are connected.
It must be, I think they have off.
Yeah, there seems to be a problem in the office.
Right. Good afternoon, Dr. Arora.
Namaskar.
नमस्कार अशोक गुप्ता जी को नमस्कार भाई
Ashok, namaskar.
सब दो लोग
नमस्कार जी।
नमस्कार
हाँ,
डॉक्टर
दीपक,
दीपक साहब
नमस्ते।
नमस्कार
दीपक,
देखे
नमस्कार। आई थिंक
नमस्ते।
साउंड चला गया कुछ।
हाँ
नहीं
मेरे
आ
ख्याल से उधर ही से गया हम लोग तो एक दूसरे से कनेक्टेड हैं
हाँ, दैट्स इज
प्रॉब्लम
वेरी।
प्रॉब्लम सेक्रेटरीट में है।
हाँ, नेम्स के साइड में कोई प्रॉब्लम है।
प्रॉब्लम
नमस्कार साहब, डॉक्टर
हाँ,
चुरामानी, नमस्कार everybody.
नमस्कार मैडम सरोज, हाउ आर यू?
Sir, madam.
I'm fine and I'm eagerly waiting to welcome you all at our IIT Kanpur.
Yeah, I now I went. Yeah, did you learn? I was at IIT Kanpur last
No, I
week.
did not.
We can start it.
No, I was there. Yeah,
Very good.
Oh my God.
yeah.
That's a good
Wish I knew
good
it
intermission.
earlier.
I think everybody
Yes,
needed that.
Good intermission.
Yeah, I'll come again. Yeah. So there was a meeting of biomedical engineers at IIT
आप
Kanpur.
start कर दी then. I think we can start it again. We can resume the talk.
Please.
Yes. Thank you. So yes, I'm almost finished, and we were just talking about the way they planned the analysis, and of course, do remember this is a hypothetical analysis, which is based on the randomized control trial data and other relevant data, and this is what is known as the Markov model, where you look at all possible ways in which a patient can behave. So if you have a symptomatic patient, which is your starting point, symptomatic asthma, then you can become symptomatic. The patient can become symptom-free, can have a mild exacerbation, which is treated in the British concept with inhaled steroids at general practice. You can have a severe exacerbation where the patient comes into hospital. The patient can then recover and then bounce back into a state of exacerbation, or the patient can recover and get better and then might have a further episode. And this is the way the asthma patient's life goes on. So if you look at that model in the context of genotype therapy versus standard therapy, then this is what you find. And this paper has been accepted for presentation at the Amsterdam ERS conference, but Sean, who is the senior lecturer in Manchester, is writing up the paper. And this is usual health economics data, which we doctors will find it extremely difficult to penetrate, to make it penetrate to our heads. But in the simplest possible language, the message is that the genotyping strategy is dominant, it saves cost, and it avoids exacerbations. What you are basically finding is that there is a 470 pound saving for every patient over that 6-year period. And over that 6-year period, in a country the size of England, which is obviously much smaller than what you're thinking of in the Indian context, in a country the size of England, there'll be 75,000 plus patients who enter into this cohort, and the genotyping at that point, age 6, will avoid 55,000 plus exacerbation, which includes up to 21,000 severe exacerbations. So that's actually quite a lot. And in terms of money, that's saving 35.5 million pounds to the NHS. So if you look at the cost of genotyping, which is like 10 pounds, 20 pounds, and it's a one-off. It's a one-off. You don't have to, my genotype doesn't change all my life. So just one genotyping of this particular adrenoceptor genotype for the rest of my life, if it saves me from 2 asthma attacks, it brings back the money to the government, to the healthcare service, to the patient, whichever way you want to cost it. And of course, the costing will be done very differently in India, where a lot of the care is delivered privately. Whichever way you look at it, somebody saves a lot of money. And that was the message. So I'd like to argue that the road to implementation, we've progressed quite a lot. And we are left with the question of embedding in clinical practice. And that is where the NHS pharmacogenomics network of excellence came in. We had an interesting consultation. They analyzed the data landscape, and they are moving now towards a webinar of key stakeholders. And these are the key issues that came up, which may be of interest to people here who are trying to think of innovation within medicine. With all this data, with this kind of information, is it acceptable to children and clinicians? This was a point raised by the network, and we are trying to argue that we've got that data from Pristine. What type of evidence can convince clinicians to adopt the test and treat strategy? At the end of the day, the doctors and the patients will have to accept this. What is the study design? Is there implementation? Shall we now go ahead with implementation, or is there equipoise? Uncertainty, where a further RCT is required. We wish to argue that there is not much uncertainty anymore. But we would like to present this to the webinar and take it forward. Where will the implementation study take place? Is it going to be in primary care or in specialized pediatric respiratory clinics like the ones Joseph runs? Which is the best setting, or both? What sites would be required? Diversity is a very important issue, which I have not mentioned at all, which is that the genotype is far more common in non-white patients than in white patients. So 15%, all that data is white. Because I did my studies in Scotland, 99% of the population is white. We know that the adverse RGR genotype is more common in Indians, even more common in, actually, apparently most common in Chinese. So opens up a huge can of worms there, which we have not even touched. And how many participants do we need to power against the primary outcome, or do we just go ahead with the implementation study? And I wish to end by thanking all my collaborators, all my funders, who have played a very, very critical role in the development of our hypothesis, coming forward to this point where we are. And please contribute to the discussion by joining Onesizefits1, all of you who have got Instagram and Twitter access. And I look forward to meeting you again in the future. Thank you very much.
Thank you, Professor Somnath, for giving an idea to us about a new area of therapeutic approach, how to manage bronchial asthma, specifically in children. This is a new area. In fact, this is not very commonly practiced for bronchial asthma. Of course, we know that you also told in the beginning, like other areas like cancer, cystic fibrosis and other areas. So this, I am sure this will generate a lot of interest. We have got pediatrician colleagues, other chest physicians and others. So now, sir, I should go with some question answers. You'll be
yes, definitely happy to take questions.
Question answers.
Comments.
Yes. It is, I must compliment it. It was a very exciting talk which you gave. 2-3 comments and maybe questions for you. You mentioned that it's true that, and the pediatrician will echo that many children, they do not respond adequately with LABA. And I've seen the trend changing. Now people started keeping montelukast as a first line of treatment, whether it's right or wrong. But trend is changing because some people found response to that and they thought that this is better without any clinical evidence long term. The question here, which you have mentioned in the last slide, are so relevant that whether there is ethnic variability in India, whether the same type of polymorphism exists in Indian population, particularly in so diverse population, where AA and AG and GG, the frequency of this polymorphism same or not, which will determine that. And that warrants a collaborative study between what you said, particularly, and I'm very happy to say that we will be very happy that if all aims can collaborate in a network and a consortium more that. Having said that, there are two important things is, see, in times to come when the genomic profiling would be affordable, accessible, and practical solution at the place of tertiary, secondary, and primary hospital, and knowing the fact that AA and AG, they respond better to montelukast or maybe leukotriene antagonist, and GG, which is 37%, whereas 63% is the. Can we say that the first line of treatment empirically should be montelukast? Maybe till the time it comes. And then, if so, maybe the post-marketing surveillance can provide an answer to this. What's your response to this?
Yes. So montelukast has had a recent bad press.
And just let me also complete. The cost of montelukast is 4 times more than the simple LABA. And particularly when you talk of HTA, I think now is the challenge.
Yes.
And finally, I would say, when LABA in the first group, the montelukast respond better than LABA, and in the GG group, the LABA respond better. But both they respond.
Yes.
Both they respond. So how you address this challenge?
So LABA, does everyone respond to LABA? That is a good question. Now, we don't have an answer to this question because some patients who are judged may not actually respond to LABA at all. So these could be, I'm saying, because I haven't done, but we all know there are patients who are being treated with lots of medicines who keep getting unwell. And we currently call them difficult asthma. We currently call them difficult asthma. We don't know what to do with them. We give them azithromycin or this and that, increased dose, lots of steroids, oral steroids, so on. So if some of these patients could very well be having this kind of genetic polymorphism, either in terms of LABA, either in terms of BT2 receptor or in terms of steroid receptor. Because along with this, with the help of our Dutch colleagues, we published a couple of papers, which I haven't had the time to follow up because I've been more fascinated with this story. But the fact is that with steroid receptor variation, you also get differences in response. And the Dutch group led this work. Anke Hilse led that work and did the analysis on combined cohorts, on our cohort and their cohort, Pacman and our cohort. So all these finer nuances are there, which will undoubtedly unfold over the next 10, 15 years. And the way we practice medicine, I think, will completely change. It'll probably be on the screen here. I will have the younger people here in this audience, he'll be gone, will have this genetic profile of the patient, which will point towards this particular form of therapy. And that could be take it easy on inhaled steroids, or it might say take it easy on the long-acting beta-2 agonist. It might not work in your patient. Go for LTRA. Go for muscarinic agonists. Tiotropium is now licensed 4 years and above. We are not using it. Well, we certainly are not using it. We haven't got the experience. The Dutch and the Italians invariably double the dose of inhaled steroids. We in Britain have been more conservative about using higher doses of inhaled steroids. Now, they aren't. They just go for 800. They just go for 400, 600, 800 fluticasone instead of going for LTRA. So there are many other options that people are using. And that, again, is something that might play a bigger role here. So actually, we are now rolling out the clinic. We're just slowly testing the water. The next clinic that we are starting, hopefully starting up by the end of this year, we are going to be genotyping. Tom has got a panel of, I think, about 13 different polymorphisms that he has picked up on doing a systematic review of the data. And that certainly includes the leukotriene receptor polymorphisms as well, because you can get leukotriene receptor polymorphisms which lead to poor response in Montelukast. And whoever has used Montelukast knows that 50% patients or maybe 40% patients don't respond to Montelukast. So you have got this map coming up there. It's just waiting to happen. And that is how we need to move forward. There's no one single answer for our, if that answers your question a little bit.
Yeah, perfectly. I think you answered very well. And my quick, short, in absence of this facility of genomic profiling in India, so commonly available, because that is, of course, maybe 10 years later, the scenario may change. Can we develop an algorithm that, yes, if this is a patient is not responding to LABA for X period, then you shift to Montelukast or vice versa?
Absolutely. I mean, this is what I think, this is why I wanted to come and talk here. This is the absolutely correct point, coming as it has to from a pharmacologist. This is exactly what we need. When we don't have genotyping, we can still make use of our knowledge. Pharmacology is teaching us these lessons. We have to imbibe those lessons and we have to respond with the resources that are available. And that's absolutely right. This should be embedded within our clinical practice, whatever guidelines we follow. We have to say, look, we know that some patients will not respond because of this reason. So how soon shall we review that patient, or even what information are we going to give to that patient, and thus be able to pull back quickly and prescribe a different medicine? And this is the choice. This is the menu of medicines. So I think this is really important, and that can be done before the genotyping is. A day will come when everybody will be genotyped. The whole Indian population will be on the screen. I don't know how many years. India is progressing at such a rapid pace. It might happen in 30 years. It'll probably happen before it happens in Europe. And it will be available, and people will do it. So, but in the interim, we can still help our patients. I think that's a very important point.
Being a clinician, from a clinician point of view, we have eosinophilic and non-eosinophilic asthma. And then we have, stress-induced asthma. We have other recognized clinical markers like aspirin, exercise-induced. Is there any correlation which you can suggest, because to get genotypic done right at the outset, from your clinical, have you correlated with the basic clinical characteristics of your cohorts?
The answer is no. We haven't.
You've not done.
No.
Because that
you're absolutely right. So that is part of that big map that
because that would be of real benefit to we clinicians.
Yes, absolutely.
Because to afford like genomic studies in my own country.
Yes.
I mean, it would be much easier for us, to have a
Absolutely.
correlation between eosinophilic, non-eosinophilic, exercise-induced asthma, aspirin-induced
Yes.
asthma, something like that.
Yes. I think you're right. Asthma is not one disease. It's an umbrella term. And we'll get there in 20, 30 years. Joseph.
Thank you, sir. First of all, I'd like to thank and congratulate Professor Mukhopadhyay for this brilliant piece of research over several years. And not just on focusing on the efficacy part, which is what most of us researchers do, but also looking at those gap areas. Do patients want it? Will they accept it? The health economics, making it a complete package of things, right to embedding it into this. So I thank you for that, sir. I don't have a question, but I have three quick short comments for us to deliberate on later. One is we use the same medications even in acute asthma situations, the same beta 2 agonists and things like that. And so if this plays out in exactly the same way, it would be very useful to look at this in acute exacerbation settings as well. And there is where we could do lung function tests and all that and have objective parameters besides the patient-centric outcomes which you're focused on. Food for thought. The second is, I think this highlights the fact that in much of the research we do, we go by the majority. So in any kind of A versus B comparison, there is always a group which doesn't respond, but we look at the measures of central tendency like the mean or the medians, and then we just apply that across the board for everybody. And now when we start looking at the confidence intervals and the ranges, we'll always find in every kind of comparison, there are people who have not responded as well as those which are the majority. So I think this would necessitate for us to look back at lots of other medications and lots of other conditions to see whether we are missing out people, even in trials which show definite efficacy, that have not responded as well. And the third thought which comes to mind is, now all this study has been done in asthmatic children who have been under therapy for a long time. If we move this data or study to the population, it would raise the interesting question of, are these mutations or changes in genomics happening under pressure of using the beta 2 agonists, or are they innate mutations within the population, which means a chicken and egg controversy? So is it because people have been taking a lot of beta 2 agonists that some of their cells are now behaving differently and thereby escaping, like happens with the drug resistance with antimicrobials and things like that? So it's a fascinating area of research, and we'll be very happy to collaborate with you, sir, to take this forward. Thank you very much.
I think this is really interesting. Yeah.
There is somebody is raising hand in the VC, and then you, sir, and then Dr. Ted.
Yeah. So can I come in?
Yes.
Yeah. So very nice talk. I've been listening very carefully and very nicely moderated by Dr. Gupta. So it's a wonderful listening here. So I'm Dr. Deepak. I'm a physiologist. So we published a research recently, 2024, that the Indian population has a diversity in genomics when you compare in autonomic responses. And we took the Ayurveda types, Vat, Pitta, Kapha, and we found their stress responses, especially the blood pressure response. So there is a diversity in Indian population. And but more pertinent question would be, does it change with time? So if it is changing with the time, how would you keep, because the epigenetics is coming up and over the years we have seen people changing. So the diversity is there, which is known. It is prevalent for the several stress-related responses, autonomic responses, where we have been researching in bronchial asthma. We have shown that by yoga, you can modify the exercise-induced bronchial asthma. And we correlated with several biomarkers. So my question is, if it's changing by epigenetics, how do you keep those things constant over time? Otherwise, it's a cat and mouse game. You focus on minority because it's significant minority, and then you shift the whole paradigm to personalized medicine. I remember in the childhood when those family physicians were there, even the Ayurveda type, they were having family history known, and they were treating like kind of a personalized medicine. So I'm still wondering, personalized medicine versus the whole medicine when there's a changing paradigm in terms of mutation or epigenetics. So how do you respond to this?
Well, this is why it is wonderful to talk about personalized medicine in India because, of course, Ayurveda is the birthplace of personalized medicine. I mean, it was personalized medicine. Without the genetics, they did everything else. They didn't do the saliva test. They didn't have knowledge of the human genome, but they tried to characterize the human being, very, very intensely, and they came up with these wonderful maps. So yes, you're absolutely right, and I think that's why I really feel that India is the place where genotyping will probably be the most accepted, because people who belong to that culture will say, we know this. This is what our ancestors have taught us for hundreds of years. Ayurveda and Unani as well, which is also flourished in India. They all relied on personalized medicine. So the philosophy is embedded within. Mind you, it was probably embedded in the West as well, before we started looking at randomized control trials as the answer, for very good reasons. Very good reasons. But yes, but certainly, there is no doubt. What you say is absolutely relevant.
Thank you, sir.
Like, may I come in?
Just a minute. Just a question here, then you tell. Yes, sir.
Thank you. Thank you, sir. And first, I would like to compliment Dr. Mukhopadhyay for such a wonderful, beautiful piece of research that he has shared with us. I would also like to congratulate NAMS for bringing in a pediatrician and indicating towards the importance of origin of diseases. So here we find that Dr. Mukhopadhyay's work is something novel, which actually is trying to shift our understanding about asthma as a whole. It also reminds us that cystic fibrosis is also a prototype disease with CFTR modulator therapy coming up, and all physicians and diseases looking towards this disease for a modulation therapy. Sir, I would like to comment that this phenotype-genotype correlation is well known even in asthma, but you have given a kind of a different model. Of course, this was not a very precisely and well-studied issue, and your team has worked over years to prove this, what you have shared today. It's very heartening. Congratulations. Sir, my question is that in GINA guidelines, grossly they have defined less than 12 years and more than 12 years as totally different cohorts. And the medications we give are also different. And we know that in less than 12 years, we would not prefer giving montelukast. This is the first question. So what is your take and what is the results from your study in this regard? And the other thing is about montelukast, which comes with a black box warning in our adolescents. And you have used it in many of the adolescents. So what was your study's experience, and have you brought it out as a limitation or something which needs to be considered further?
It's definitely a limitation that has to be considered. And that is why I keep saying montelukast is not the only medicine that we can go for here as the alternative to LABA. There are all these other choices. The black box warning, I think, came from the case in New Zealand where a child committed suicide, and that naturally shook the world. But again, if you look at only medical history will tell what was the reason. And you might find that there are particular genes, neurology-related, brain-related genes that have modulated the process there. It may be the environment. Maybe there was something particular about the environment. I don't know the full story. And we may never know the full story, but we will. But this is generally what happens. Thousands of children get montelukast. Many of these children get some side effects here and there. Of course they do. and traditionally we have told parents, use it, see how it goes. I still do this. Because in Britain the rules are not as strict. In Britain we still use Montelukast. So I still prescribe Montelukast, and we say to mums, use it, see how it goes. If your child is tolerating it, my own daughter takes Montelukast every day. Inhaled steroids did not work very well with her. She takes Montelukast. She takes a single tablet of Montelukast. She's been taking this for the last 10 years. She's a prime example in front of my eyes of somebody on Montelukast. So, every child is different. And that is where I think medicine will change. This kind of guidance is fine, overall guidance, but firm rules are very difficult in medicine. If we go back to those days where you decided on an individualized basis, the point that Dr. Deepak made, that we have practiced individualized medicine for thousands of years in this country, in this society. And I think we just have to say to modern medicine, look, individualized medicine, we know more about individualized medicine than literally anyone else in the world. That was the firm basis of Ayurveda. And I find that really interesting, the way Ayurveda comes in here into the story.
Thank you. Thank you very much. I think since lunch is waiting in, but my old classmate, Dr. Rajendra Prasad, is waiting here. So maybe last question or comment from Dr. Rajendra Prasad.
Thank you.
After Dr.
Thank you.
I didn't see you.
Okay. Thank you. And I must congratulate Dr. Somnath for a very thought-provoking lecture. I'll take you a little history. When Montelukast came in India, I think it was in around around 1995. I was the first clinician. I'm basically a hardcore clinician. So first lecture I took on Montelukast, when it came, since it was an oral drug. So we have a lot of fun and fair that probably everything will change in asthma. But in that lecture, I still believe, I said one of the slides with the evidence that Montelukast is not panacea for every patient of asthma. It may work in about 1/3 of patients. Who are that 1/3 of patients? At that time, probably it was very little known. But now I'm happy, and Dr. Mukhopadhyay has come up with a great research that yes, there are some segment of the patients where there are some this genotyping and this much where it can work. Because another point I would like to raise, the Montelukast, unfortunately, in India, when we see in last 30 years, since it is an oral drug, so it is highly being misused. It is used right, left, and there. So I think your research, Dr. Mukhopadhyay, and you should more know that what are the patients, in which patients this can be a wonderful drug. I still remember my words when I delivered in 90s, long back. I was assistant professor at that time in KGMC. I delivered that lecture that yes, in some of the patients, it could be a great drug to manage and to control and to prevent even exacerbation of asthma.
I think Dr. Rajendra Prasad, you made it a point. There are two drugs which are now considered as the most misused. One is a pantoprazole, and another is a Montelukast. So these are the two drugs. In one of our study, we found that these are the two drugs perhaps most commonly not rationally used. Dr. Sanjeev, last question.
Thank you very much. Excellent talk by Professor Mukhopadhyay. Sir, I'm Dr. Sanjeev Sinha. I'm Professor of Medicine at AIIMS, New Delhi. In my adult chest clinic, we see many cases who are coming with the underlying environmental factors and trigger factors like fungal diseases. So we have seen in ABPA and other fungal diseases, patients develop chronic kind of bronchial asthma. So what are your thoughts about that?
I don't know. This is not an area that I have any expertise in, I will be honest. But fungal problems present differently in the UK. They present with allergic responses. I mean, I suppose ABPA is also driving the process through an allergic response. And it's probably different in different societies. So in Britain, in contrast, I'll give you an interesting contrast. Very different setting. Cold houses, poor people now. We can't heat our rooms because we have gone poorer. 75 years we don't have any colonies. Where are we going to get our money from? So we have got a problem there. Living standards are falling all the time, and industry is not flourishing. So there is a lot of mold in the house.
Yes.
There are no money anymore, no grants coming in from society. Fungal molds are driving asthma in children. Very, very, very important problem. And it is completely different scenario, but exactly similar pathological process. And it's another area that I'm really interested in.
So I see that a lot of questions are bubbling from many online as well as present here. But I can see Dr. Kapil is restless.
No, I'm not restless.
No, it should be.
We have a meeting at 2:00, sir.
That's why I know I was just going to say that. And so I think extremely thankful to you.
Thank you very much.
And extremely thankful to those who raised very pertinent, and this session would have gone till 5:00 had there been the freedom.
Thank you, sir.
Thank you very much, Dr. Somnath, for excellent presentation. We have a small token of memento, our appreciation, a plaque by Dr. Behra. Sir, you please come in the front, sir. Come in the middle.
Can you?
I come there? Yes, sure.
And a small memento. Thank you, Professor Talwar and Dr. Behra. May I request Dr. Sood to deliver vote of thanks.
On behalf of the National Academy of Medical Sciences, it is indeed my great privilege to thank the distinguished speaker for this afternoon, Professor Mukhopadhyay, sir. Thank you so much for sharing your experience of several years with us, especially this new modality of treatment of exzema and asthma. I'm sure that it has given a lot of ideas to all of us, especially our clinical colleagues. Thank you so much for your valuable time. Special thanks to Professor Behra, sir, who has been constantly encouraging us to have this series. And this is perhaps we have started, and we look forward for your blessing in future also. We have with us a former DGHS, Dr. R.K. Srivastava, sir. Thank you so much for your support and blessing to the Academy. Thank you for your valuable time. Professor Y.K. Gupta, sir, and Professor K.K. Talwar, thank you so much for co-chairing this session and generating a lot of discussion. Special thanks to Professor Talwar for ensuring that this event happens. He has been in constant touch with the speaker. Thank you so much, sir, for your blessing. Special thanks to our colleagues from PGI Chandigarh, AIMS, ICMR, and many more who have joined us online. Special thanks to our council members, our state coordinators. Dr. Ranganathan is here, sir. And also family members and all the students and medical college faculty member. Your presence has been a source of great encouragement and for us, and we look forward for your blessing in future also. Once again, thank you all for being with us, and we invite you all for lunch outside this hall. Thank you so much.
आ जाओ डॉक्टर साहब, ये इनका दोनों का गाड़ी में रखाना होगा।
हाँ फोटो आ जाएगी ना, क्यों हटा रही है, फोटो आ जाएगी। फोटो आ जाएगी रहने